Hi again, this is Michael Altos recording the next in a series of lectures on the allergic response corresponding to Berish Chapter 12, and this is Part 2. We're going to take a few minutes and review the different kinds of hypersensitivity reactions, and there are 4 types. The first is the type 1 reaction, which is an anaphylactic reaction or other immediate type immune reactions. In these reactions, some antigen binds to IgE antibodies, usually located on mast cells or basophils, and when that happens, the cells release a variety of different vasoactive mediators. Usually, for this to happen, there's a prior exposure to antigen, which gives the system some memory. So we don't typically see a full-blown type 1 response unless the patient's had a prior exposure. The onset of symptoms can be 5 to 10 minutes after exposure, although I've seen data that suggests the onset can be even sooner than that, and the time from exposure to cardiac arrest can be within 5 minutes. Symptoms we see include urticaria, pruritus, laryngeal edema, bronchospasm, hypoxemia, and even total vascular collapse. These patients can extravasate up to 50% of their intravascular fluid, and this is due to a sudden increase in capillary permeability, and management of this will be discussed a little bit later in the lecture series. A type 2 hypersensitivity reaction is called an antibody-mediated or a cytotoxic reaction. These reactions involve IgM or IgG antibodies, and in these cases the antibodies bind to either an antigen on the surface of cells or a hapten on the surface of cells. And examples of these reactions would be like ABO incompatibility, where here we have some sort of a foreign antigen being presented on a cell. In that case, it would be a red blood cell. And then an immunoglobulin recognizes that as foreign and attacks the cell and marks it for destruction. So ABO incompatibility, which leads to hemolytic anemia, as well as other drug-induced hemolytic anemias or heparin-induced thrombocytopenia, which involves destruction of thrombocytes. A type 3 hypersensitivity reaction is called an immune complex reaction. These are heavily involved with complement, and typically what we see is a circulating antigen binds to an antibody, and this complex deposits in the microvasculature. This leads to activation of complement, and in come the neutrophils, and this leads to an inflammatory response. So we see this a lot in lupus, post-streptococcal glomerulonephritis, and other examples of nephritis and vasculitis. Some think that the protamine-mediated pulmonary hypertension is due to this pathway as well. Finally, the type 4 hypersensitivity reaction is what we call a delayed hypersensitivity, and the onset after exposure can be 18 to 24 hours and lasting for up to 96 hours. These usually involve lymphocytes binding to specific antigens, and these kinds of reactions are commonly seen in patients undergoing tissue rejection or contact dermatitis. The TB immunity response that we see are all due to a type 4 delayed hypersensitivity response. We'll pause here for just a moment. If you have any questions, you can jot them down and bring them to class or get in touch with me and we can discuss them further. Now we're going to talk about the perioperative allergic reaction, which has an incidence of anywhere between 1 in 3,500 to 1 in 20,000 cases. Notably, 4% of patients who have a perioperative allergic reaction die. So this is very significant. And 90% of them occur within 5 minutes of IV drug administration, although some of them can be delayed by up to 20 minutes. The key player in an allergic reaction is usually histamine. Remember, this is a naturally occurring amine which is involved in the mediation of inflammation, and it's secreted from mast cells and basophils. Mast cells are located in the skin, the lungs, and the GI tract, whereas basophils are circulating cells. The H1 histamine receptor is what I think of as the allergic receptor. It's the one that, when histamine binds to it, leads to smooth muscle contraction in the respiratory and the GI systems, and you get bronchospasm. Patients also have pruritus, which is itching and sneezing, release of nitric oxide, which causes peripheral vasodilation, thus the flushing and perhaps the rash. And also there can be some decreased AV node conduction, leading to bradycardia or even coronary vasoconstriction. These are all effects of histamine at the H1 receptor. The H2 receptor is what I think of as the GI receptor. So we get a lot of gastric acid secretion, increased myocardial contractility and heart rate, and some coronary vasodilation. And there is a H3 receptor, which we don't usually talk about. It's primarily a negative feedback receptor, so that when histamine binds to the H3 receptor, this inhibits release of additional histamine and synthesis of additional histamine as well. Let's take just a moment and clarify a few terms. Many of you have probably heard the term anaphylactoid, and this is a term that is no longer used by the mainstream people in the immunology world, because anaphylactoid reactions clinically look exactly like anaphylactic reactions. And really what we're talking about is, while an anaphylactic reaction is exposure to a small amount of allergen that precipitates this cascade, this chain reaction of immune-mediated response, the anaphylactoid reaction was really just a dose-dependent, non-immunologic histamine release, and usually due to some activation of mast cells. So nowadays, instead of using the term anaphylactoid, we just talk about immune-mediated and non-immune-mediated histamine release. In these patients, you could pre-treat them with antihistamines if necessary, and many different drugs are responsible for these so-called anaphylactoid reactions, including antibiotics like vancomycin. The red man syndrome is a classic example of a dose-dependent, non-immunologic histamine release. But we see it with other drugs like hyperosmotic agents, neuromuscular blockers, opioids, and even thiobarbiturates. The anaphylactic reaction typically does not occur unless the patients had a prior exposure to the antigen. And upon re-exposure, the IgE antibodies that have memory of this antigen cross-link and start the anaphylactic reaction. The mast cells and the basophils release histamine, tryptase, leukotrienes, and cytokines, which mobilize the immune response. Patients experience bronchospasm and upper airway edema. Peripherally, they have vasodilation. As capillary permeability increases, patients become hypotensive and can eventually have circulatory collapse. Other signs and symptoms include, as we said before, urticaria, flushing, swelling, and edema, and symptoms can persist for even greater than 24 hours. All of these 6 pictures are here just as a reminder to us that all of these pictures actually have the exact same diagnosis, which is hives. And this is a good reminder of how different hives can look in different people at different times. How do we manage anaphylaxis? Well, the first step is to remove the offending agent. So if we can identify the antigen and remove it or limit it or stop its administration, that is the first step. After that, our primary goal is to maintain and evaluate the airway. So if the patient is intubated, that's fine. And if they're not intubated, airway protection may need to be considered. We usually put them on 100% oxygen. It's important at this point to stop the inhalational anesthetic drugs, and many people forget this in the heat of the moment, but clearly a patient who's undergoing a life-threatening vasodilatory condition should not be given any cardiac depressant or vasodilating inhalational anesthetic agents. One of the mainstays of treatment for these patients is intravascular volume expansion, and these patients may need liters and liters of fluid. Remember that, as we said before, as much as 50% of their volume can be lost to the interstitial space. And in these patients, there's no data to support crystalloid versus colloid. Whatever you have is fine and is the optimum treatment. The next most important thing is epinephrine. Epinephrine has several goals. It restores the membrane permeability and reduces bronchospasm, as well as increasing vascular smooth muscle contraction, leading to improved blood pressure. And those would be the alpha effects of epinephrine, increasing blood pressure. But there are beta effects as well, leading to bronchodilation. So epinephrine is really the ideal and probably the single most important drug in the first-line management of anaphylaxis. If they are hemodynamically stable, 5 to 10 micrograms IV would be a reasonable first dose, titrating up to as much as 1 milligram is needed. And if the reaction isn't life-threatening, you might consider a sub-Q or an IM dose of 3 to 500 micrograms, so you'll get a little bit more of a prolonged response and less of the acute spike in serum epinephrine levels, leading to hemodynamic instability on the other end with hypertension and tachycardia. Just as a comparison, an adult EpiPen contains 300 micrograms of epinephrine. Don't forget an infusion. If patients get epinephrine, it's only going to last for a few minutes and then it will be gone, and they may need a second dose. These patients may benefit from an epinephrine infusion. Only after you've discussed all of these things and addressed them should you start thinking about antihistamines. Antihistamines are going to help prevent the response to an increased histamine release in the systemic circulation. These drugs are usually given slowly because people can develop some antidopaminergic hypotension. And antihistamines aren't going to help if the mechanism is some sort of leukotriene-induced negative inotropy. It's not going to help with bronchospasm very much. And while we're talking about antihistamines like diphenhydramine, which is an H1 blocker, don't forget that many people like to give H2 blockers. Indications are unclear, although as we discussed before, if we see some cutaneous swelling, H2 blockers seem like they would be an appropriate treatment. So now that we've talked about the most important first-line treatments, oxygen, removing the offending agent, turning off your volatile anesthetics, giving fluids and epinephrine, and then maybe some histamine receptor blockers, we can move on to other treatments for anaphylaxis. These include bronchodilators, corticosteroids, which take several hours to have an effect. A typical dose might be 0.25 to 1 gram of hydrocortisone, or 1 to 2 grams of methylprednisolone. And then other supportive treatments, for example, sodium bicarbonate to treat acidosis, other pressors like norepinephrine or vasopressin for persistent hypertension, and refractory shock. We're going to stop this section here. If you have any questions, please let me know or bring them to class, and we will continue with the next recording.